For most of a woman's adult life, heart disease looks like a problem that mostly affects men. Then menopause happens, and within a relatively short window, that gap narrows dramatically. This isn't a vague, mildly worse with age trend. It's a sharp, well-documented shift with a clear biological cause, and it's one of the most important, under-recognized turning points in a woman's cardiovascular health. Let's go through what's actually happening, why it happens specifically at menopause rather than gradually with age alone, and what the research says you can actually do about it. The core reason, estrogen was doing more than most people realize. Before menopause, women have a meaningful cardiovascular advantage over men of the same age, and researchers have understood for decades that estrogen is the primary reason why. According to Dr. Delisa Fairweather, a cardiovascular disease researcher at the Mayo Clinic, estrogen provides a genuinely protective effect against heart disease, largely by helping to prevent the inflammation that contributes to plaque buildup inside coronary arteries. When estrogen levels decline sharply during menopause, several things change essentially at once. Dr. Fairweather has described this shift directly. The way plaque forms in the arteries changes, and the likelihood that a plaque will rupture increases, to the point where a postmenopausal woman's cardiovascular risk profile starts to resemble a man's, from an immune system standpoint. That's a striking way to put it, but it reflects a real, measurable biological transition, not just a loosely correlated trend. Beyond inflammation, estrogen also plays a direct physical role in keeping blood vessels relaxed and functioning normally. According to the American Heart Association's Go Red for Women program, estrogen helps keep blood vessels open and flexible, and as estrogen declines approaching menopause, cholesterol becomes more likely to build up along artery walls, a process that can raise the risk of both heart disease and stroke. It's not just estrogen loss. Several things change together. This is an important nuance. The menopause-related increase in cardiovascular risk isn't caused by one single factor operating in isolation. According to a 2020 American Heart Association scientific statement on the menopause transition and cardiovascular disease, several changes happen together during this period. Women tend to accumulate more abdominal fat, cholesterol and blood pressure often rise, blood sugar regulation can worsen, and arteries themselves become measurably thicker and stiffer. Samar El-Kudri, a professor of epidemiology at the University of Pittsburgh, who chaired the writing committee for that 2020 statement, has described this cluster of changes as forming a pattern that resembles metabolic syndrome, generally defined as having at least three of the following: abdominal obesity, high triglycerides, low HDL, the good cholesterol, and elevated blood pressure or blood sugar. According to University Hospital's OB/GYN Dr. Corinne Bazella, low estrogen is specifically linked to increases in blood pressure, LDL cholesterol, and blood sugar, along with a decrease in lean muscle mass and reduced flexibility in blood vessels. There's also a less obvious connection worth knowing about. Research has found that menopause-related hot flashes and night sweats are linked to a greater risk of high blood pressure and other cardiovascular risk factors. And separately, that depression occurring during the menopause transition is strongly associated with higher cardiovascular disease risk. These aren't symptoms most people would naturally connect to heart health, but the research consistently ties them into the broader picture. How sharp is this increase? Really? The scale of this shift is significant enough that it's changed how cardiologists think about screening postmenopausal women. A meta-analysis examining risk factors for coronary heart disease, specifically in postmenopausal women, published in 2024 and drawing on data from over 294,000 patients, cited a striking figure from earlier clinical research. The risk of death from coronary heart disease in women increases roughly sevenfold with every 10 years following menopause. More recent research presented at the American College of Cardiology's annual scientific session in 2024 reinforced how quickly this catches up to men's risk levels. Dr. Ella Ashaya, an internal medicine physician and the study's lead author, found that postmenopausal women's cardiovascular risk can rise sharply enough to become comparable to that of men of a similar age and health profile in a relatively short period of time. She specifically noted that after menopause, women shift toward a more testosterone-heavy hormonal profile, which affects how the body stores and processes fat and even how blood clots, all of which contribute to rising heart disease risk. Dr. Ishaya also pointed out something important about screening. Women are often underscreened and undertreated for heart disease, particularly after menopause, when they take on a range of new risk factors many are not even aware of. Timing matters. not just the fact of menopause itself. Research has identified some specific timing-related factors that further shape a woman's individual risk level, beyond menopause happening at all. Women who go through menopause before age 45 face a significantly higher risk of coronary heart disease than women who reach menopause at a typical age. Conversely, research cited by the American Heart Association has found that women who experience natural menopause at a later age tend to have lower cardiovascular disease risk and mortality. This suggests it's not simply about aging in general, but specifically about the duration of estrogen exposure across a woman's lifetime. The cause of menopause matters too. Menopause brought on by surgical removal of both ovaries at a young age is linked to a higher long-term cardiovascular risk, since it triggers an abrupt hormonal drop earlier than natural menopause would. Interestingly, the same surgery performed around the typical age of natural menopause doesn't appear to carry that same elevated risk, and a hysterectomy alone, without removal of the ovaries, doesn't appear to meaningfully change cardiovascular risk either before or after menopause. Why symptoms can look different and get missed. This is a genuinely important safety point. The 2024 meta-analysis on postmenopausal coronary heart disease specifically noted that symptoms in this population are often atypical. Rather than classic chest pain, postmenopausal women may experience chest tightness, shortness of breath, fatigue, nausea, or vomiting, often without any clear connection to physical exertion. The researchers noted this pattern contributes to both misdiagnosis and underdiagnosis, compounded by the fact that women in this age group frequently have a lower perceived sense of their own risk, which can lead to delays in seeking care. This matters enormously in practice. If you're a postmenopausal woman experiencing unusual fatigue, shortness of breath, or a vague sense that something feels wrong, even without classic chest pain, this is still worth taking seriously and discussing with your doctor rather than dismissing, precisely because the more subtle presentation is part of the documented pattern in this population. What the research says you can actually do, given how much of this shift is driven by biological changes at menopause, it's worth being clear about what's within your control and what isn't. You can't stop estrogen decline from happening. It's a natural, expected part of the menopause transition. But the research is consistent that managing the modifiable risk factors that tend to cluster around this transition makes a real difference. Dr. Fairweather's guidance for postmenopausal women, echoed across essentially every major source on this topic, comes down to being genuinely vigilant about the standard cardiovascular risk factors, monitoring blood pressure and cholesterol levels regularly, maintaining a healthy weight, following a heart-healthy diet, exercising regularly, and not smoking. None of this is exotic advice, but the point researchers are making is that it matters more and requires more active attention, specifically during and after the menopause transition, than it may have earlier in life. Given the ACC research on underscreening, it's also worth being proactive rather than waiting for your doctor to bring it up. If you're approaching or past menopause, it's reasonable to specifically ask your doctor about a cardiovascular risk assessment, including blood pressure, a full lipid panel, and a discussion of whether additional screening, such as a coronary calcium scan, might be appropriate based on your personal risk factors and family history. If you experienced early menopause, whether natural or surgical, before age 45, it's worth specifically mentioning this to your doctor, since it's an independent risk factor that's easy to overlook if it isn't directly asked about during a routine visit. A note on hormone therapy. Menopausal hormone therapy is a legitimate and actively researched topic in this area, and some studies, including data referenced from trials like KEEPS, have examined its effects on cardiovascular measures like atherosclerosis progression. This is a genuinely individualized decision that depends on your specific health history, the timing of when therapy would start relative to your menopause transition, and other personal risk factors, and it's a conversation to have directly with your doctor rather than something to decide based on general information. The research in this area is still evolving, and blanket claims in either direction go beyond what the current evidence clearly supports for every individual. Heart attack risk doesn't creep up gradually and evenly for women the way it does for men. It rises sharply around menopause, driven primarily by the loss of estrogen's protective effects on inflammation and blood vessel function, compounded by related changes in weight distribution, blood pressure, cholesterol, and blood sugar that tend to cluster during this same transition. Within about a decade after menopause, research suggests women's cardiovascular risk can become comparable to men's of the same age. a shift many women and even some clinicians underappreciate. Because symptoms can also look different and be easier to dismiss in this population, the most useful things you can do are the straightforward ones. Know your numbers, ask your doctor directly about cardiovascular screening as you approach or pass menopause, take unusual symptoms seriously, even without classic chest pain, and treat the standard modifiable risk factors: blood pressure, cholesterol, weight, activity, and smoking, as more urgent during this specific window than general aging advice alone might suggest.